I tell you, when you get a patient, you get a patient who's been stabbed in the heart.
Yeah.
Like the knife went straight into the heart.
Yeah.
In less than 5 minutes, the paramedics have brought the patient. You've opened up the chest.
That's good
You've stopped the
time.
bleeding, and tomorrow you're having a conversation with this person. You're having a talk. That's when you realize, well, this is a different world.
We are far.
Yes. Like, we need to get to a point you can dial a number and an ambulance comes.
Okay.
Even here, right now.
Yes. But you can do that.
Which number are you calling?
That's the thing. I think there are multiple numbers.
You said we can. So which number are you calling? So tell me.
Bonyeza hapa kwa simu.
Which number are you calling?
I don't know it often.
There we
but
go.
yes, it's true.
You
It's
see,
true. That in itself is a
other
problem.
countries, people know automatically.
Yeah,
Call 911, 112. Like here, you don't know any number.
You're
If
like,
I
well, let's
collapse,
Google.
so if I collapse here, now imagine it'll be
Yeah.
up to you
Yeah.
to figure this out.
Hey, yeah, that's already a problem.
What you said, we are not not used to having emergency services.
Yeah.
And sadly enough, yes, the ambulance is in Nairobi. Of course, no one has a number.
Yeah.
And because it's been norm for us not to call an ambulance compared to the West. In the West, as long as you're this high and you can talk, you can dial 911.
That's true.
Yes, and services will come. So we also need to start changing our perspective as healthcare providers, and even the general public. As healthcare providers, we need to encourage our patients to call ambulances in an emergency.
Yeah.
Yes, not say come to my clinic.
Yeah.
By the time, also that's the other thing. I've seen those cases where someone is busy dying and the doctor is telling them come to my clinic.
Yeah.
But your clinic is not an emergency center.
Exactly.
And so by the time they come to the clinic, then the doctors are like, oh, you're busy dying, go to the emergency. That's
you've
too
wasted
late.
time.
You've wasted so much time.
Yeah. Hi guys, welcome back to A Dose of Health, the podcast where I give you not too little, not too much, but just enough information to help you make an informed decision. My name is Dr. Hope Simiu, and today on set I have Dr. Benjamin. I'll let him introduce himself further, but ameva scrubs. Anataka kuniaibisha.
Got a job. Yes.
Ulikuwa job, and you're going back to job.
An already job. Yes.
So the floor is yours. You can
All right.
introduce yourself.
I'm Benjamin Wachira. I'm an emergency physician. That's
Doctor.
it. Yes. Doctor, if you insist.
What? No, why are doctors Hope Simiu? I feel like there are places where I'll be like doctor, and the other places I'm just like Hope.
So it depends. I mean, it's doctor is what I do, but that necessarily me. It's not who I am. That's my job. Okay. So I do medicine, but I am Benjamin. Yes.
Pandora's box. Medics, we need to have a discussion.
Yes.
Okay. So karibu sana.
Thank you very much, Hope.
We like talking about health here.
Yes.
And something that we are seeing that is a bit neglected is the emergency space in Kenya. So we'll be talking about that. But before we get there, let me just remind them, please, if you're not following us, this is the moment we're giving you. Before we start, so that we talk, I'm giving you a minute to just subscribe, press that button, follow us on LinkedIn, Instagram, everywhere, please, guys. Just follow us, subscribe, and engage with us. All right, now let's continue. So I usually have this thing called A Journey to Inside Out. Have you watched Inside Out, the movie?
Yeah, it's quite nice. I like the first one.
Finally.
Yes, the first one was quite interesting.
Yeah.
I mean, all those voices in your head, you're like, I think, sorry, I don't know. I'm not just saying that. I mean, people, if you're hearing voices in your head, you may need to have a doctor check that out.
Probably.
But for the rest of us who can identify different voices in a healthy way, it was quite a nice movie. Yes.
Yeah. Okay. Good. I'm happy you've watched it. Especially for someone who didn't have time.
I know. I love
I'm
movies.
happy you've watched it.
Movies, yes.
And there's a second one. So maybe after this you can...
I watched the second one also.
Okay.
I was expecting it to be as good as the first one, but the first one was much better.
Okay.
I think because it introduced the concept.
Exactly.
So now the second one, I'm like, I already know the concept.
Yeah.
But the first one, loved it.
That's
Yes.
true. Okay, so how are you feeling right now, emotionally, mentally? Where are you at today, right now, as I'm speaking?
It's a very hard question.
It's just a check-in.
I'm like 24/7 exhausted. There's just a lot of things happening. So emotionally, I'm fine.
Yes.
Happy. Actually happy about many things.
Okay.
What was the other one?
Emotionally, mentally.
Mentally, I could do with a holiday. I mean, I think we all could with a holiday.
Yeah.
I mean, a beach, some ocean. I think that I could do with that.
Okay.
And what other one? Sorry.
No, that's it. That's it. Yeah.
Yeah. So I'm okay. I'm good.
Yeah.
I would rather be on a beach somewhere looking at the ocean. I think that calms me down. And yes, love it.
And we are like mid Q1. So I think this is the time where you should be looking at before Q2. Can I have a small break?
It's coming up.
Yeah.
But the amount of work I've been doing since the beginning, it's like I'm in Q3. You guys are in Q1. Me, I'm in Q3.
There's someone who said, why does this feel like Q4?
But in fact, we are both start celebrating Christmas at this point.
Oh, but Happy New Year. Happy New Year. Merry Christmas.
And then by the end of this quarter, imagine we'll have a chat about the next year.
Like wrap it up.
Wrap it up, yeah. But it's been an exciting start to the year, so it's quite nice, yes.
Okay. I think for me, what emotion am I feeling today? I think I'm also a bit exhausted. It's not an emotion, but I'm just a bit tired. Yeah, but happy to have this conversation.
Yeah, I told you, it's Q4. You guys you're seeing Q1.
Where?
To go Q3 end up or starting
When does
Q4.
it slow down? I don't know if you feel this, but like growing up, I feel like time was moving so slow. And then just because a certain age where like 1 year feels like a month.
Just for reference, I'm young. I don't know why we are being bundled up into a certain age.
I said we.
We'll go back there.
Guy, why?
Yes, for us young people, yes, life is moving a bit fast.
Yes.
Yes, at some point someone needs to put a bit of a break. Just
like
we
pause.
Just pause a bit, we breathe a bit. But I think it's because I think life is, there's life, but also a lot of things are evolving.
Yeah.
Tech is really pushing how things happen and the speed at which things happen.
Yeah.
And it's an interesting time to be alive because we are at the transition. We've transitioned somewhat from the old times where things were a bit slow.
Yeah.
These days, even the microwave needs to work a bit faster.
You're like, wait.
Why are we
what
not
needs to
eating
be
this
done?
food a bit faster? So yeah, we're at a point where I think we are definitely need to consciously stop and pause because things are moving quite fast.
That's true.
Yeah.
That's true. Now I'm just here thinking, imagine if you could forward the microwave.
You
Like
see?
times two.
Exactly. Because why is it taking this long to heat this food? Yes.
Attention span. It just shows our attention spans are...
Before someone had to go fetch firewood, blow up some heat fire
Imagine.
and wait for the food. Now,
Yeah.
this microwave needs to be upgraded. It's too slow. Yes.
Yeah. Anyway, so maybe that will be the next innovation.
It's coming.
It's coming.
Yes.
Yeah. Sawa. So now, let's go to the doctor's seat.
Yes.
Question number 1. If you could explain to a 4-year-old what you do, how would you do it in 2 sentences?
Essentially, when doctors say we save lives,
Yeah.
we are the other ones. Us, emergency physicians, we pull you out from the grave, okay, and give you a chance at life.
Yeah.
That's essentially what we do. Because we come in when you're dying.
Yeah.
Yes.
Okay. That's true. So the rest of us should not claim that.
I think, by the way, we need to have a discussion.
Yeah.
Yes. Because we're the first people who see you when you're in an emergency.
Yeah.
And if we do our work well and the stars align, you survive. If we don't do our work well, there's a high chance you may not survive or you may have permanent disability.
Yeah.
But there's sometimes, again, just caveat, we do our work well, but the stars don't align. And in which case, then, unfortunately.
Yeah.
But yes, your life, at that point where there's a life or
He's
death
saying your life depends on him.
and stars. And remember, I just said stars, focus. I said
And
stars. By the way, whichever stars,
Yeah.
whatever. Yes, because I think that's one thing I learned about emergency medicine is because you could do everything perfectly well by
That's
the
true.
textbook and the patient dies.
Yeah.
And you're like, surely, like, I have done everything, yes.
Yeah.
And sometimes you could, and it's also your expectation. You see, you do something to a patient and expect them to survive,
Yeah.
then they pass on.
Yeah.
Then another patient comes in who you can see they're really at the edge, and even with your best efforts, they may not survive.
Yeah.
But you do your work and they survive. You're like,
You're like,
I did not expect to
Okay.
survive. You will resuscitate 8-year-old.
exactly. I was gonna say it's
Yes,
children.
Exactly. You resuscitate an 8-year-old and somehow things just don't work, they pass on.
Yeah.
Then you have a 99-year-old person who you're like, hi, boss, I know it's bad, but you'll do your job.
Exactly.
And they walk out of hospital. So
Yeah.
that's why you're like, yeah, there's what we do, but there's also the stars.
That's true.
Yes.
Okay. Next question. If you were to rate 5 specialties, your top 5 specialties from 1 to 5, who would be number 1, who would be number 5, and why?
Rate them in what context?
You decide. Maybe number 5 is like the one you love the most, or number 1 is the one you love the most. You decide.
Okay.
Yeah.
So number 1, love the most. Emergency medicine, of
Your
course.
boss is not watching.
Yes, number one, I love emergency medicine.
Okay.
It's so much fun. I think number two, love critical care. Critical care, it's quite close to emergency medicine. So I definitely enjoy critical care. Number three is pre-hospital. Like I used to do it when I was training behind an ambulance. When you're the doctor who goes to get people off the streets, the doctor who goes to people's homes to save them in their homes, that thing is on another level. Like
adrenaline.
I love it. I love adrenaline. Yes. So a pre-hospital doctor. Actually, I probably put pre-hospital doctor after emergency medicine, pre-hospital doctor, then critical care.
Okay.
The other two, can I just say the specialties I would never practice?
Yeah, sure.
Gynae.
Okay. Why?
It's off. I do not understand.
It's good to be honest.
And I will leave it at that. I just do not understand OBGYN. Let's just leave it at that. Yeah. I think the other one is, which other speciality that would definitely not be practicing? I think the physician, the GP work, like the whole you are my patient, yes.
Okay.
Then I will see you tomorrow. Then the day after, my friend, yes, this whole.
Is this a commitment issue?
It is, but hey, let's just accept it. Probably is. It's as in this thing. That's why I knew even when I was finishing medical school.
Yeah.
I will not be someone's doctor.
Okay.
I will treat emergencies, but I will not be someone's doctor. Where at 3 a.m. you're calling me, telling me, oh, you're not feeling. No, surely.
3 a.m. Go to hospital.
But see, you're my private doctor. Oh, so you need to see me.
Yes, yeah.
I think I love the concept of I will see you, I will stabilize you, then you become someone else's problem. And if I see you too often, you are really on the edge here.
Yeah.
I should not be seeing. I should not be seeing you too often.
That's true, by the way.
If I see you 2-3 times,
there's a problem.
There's a problem, and we need to deal with that one. Yes, I prefer. Let me stabilize you.
Yeah.
Again, it's a commitment. I don't even need to know your name, by the way. Just move you along the system. Yes.
Yeah. Okay, that's interesting.
Yes.
Some of us, when you think of emergency medicine, when they let's say there's a code red or code whatever.
Code blue. Yes.
Code blue, code red, green. I'm normally just like, who's in charge here? And it could be you, but you're looking for who's in charge.
Who else is?
Who's in charge?
But you see, that's the problem. Actually, the problem is because we were not taught emergency medicine in undergraduate. And that's why we all get confused in an emergency because it wasn't part of our training.
That's true.
And for me, that's why I was like, let me go learn what to do because you can't always be like a deer in headlights every time someone's busy dying. You're like, I have no idea what to do. Panic. Let's all panic together. No.
Let's all panic together.
But that's what it was. It was let's all panic together, and
hopefully they survive.
Between everything that we are kind of doing, we hope they survive.
That's true.
But then, of course, in our context, in the Kenyan context, there's also a traditional part of if they don't survive, they're like, oh yeah, they were too sick, which is not necessarily always the truth. Yes.
Yeah. But we'll get to that. That's why we are here. Next question: if you won a grant today, what problem are you solving?
Emergency healthcare services. That's straightforward. Like we need to get to a point you can dial a number and an ambulance comes. Even here right now.
Yes. But you can do that.
Which number are you calling?
That's the thing. I think there are multiple numbers.
You said we can. So which number are you calling? So tell me.
Bonyeza hapa kwa simu.
Which number are you calling?
I don't know it offhand.
There we
but
go.
Yes, it's true. It's true. That in itself is a problem.
In other countries, people know automatically. Call 911, 112. Like here, you don't know any number. If
like,
I collapse,
let's Google.
So if I collapse here, now imagine it should be up to you to figure this out.
Hey, that's already a problem.
Hey.
But at least you started the work. Next question. Yes. What's one skill or habit that you feel makes you a good doctor?
Multitasking.
Yes. Perfect for your field.
You have to because you're seeing multiple patients at different perspectives and you have to keep track of everyone. So yes, men, we don't multitask very well.
Yeah.
But in emergency medicine, you have to learn to multitask.
You have to.
Because everything is moving at the same time. Yeah.
It's like IMED on steroids.
Yes, exactly. And things are happening real time, real fast. Yeah. Yes.
Okay. Now, last question before we actually start the conversation. So our episodes go up on Wednesdays.
Yes.
So, ukitumia lugha ya taifa, tueleze mada ya leo na dalili zake kidogo.
Ati mada?
The topic of the day.
Oh.
And dalili is like symptoms, but tell us
dalili
some few things.
I'm not that bad. From mada part, I was like, who are we murdering now?
Shame on you. Who are we murdering?
Mada ya?
Mada ya leo. What's the topic of the day?
Oh, okay. So leo tutaongelea leo tutaongelea Ma. Dear.
Oskis.
No. Ugonjwa za dharura. Leo tunaongelea ugonjwa za dharura.
Okay.
Na vile kama nchi yetu ya Kenya tunaweza hakikisha kila mtu anaweza pata matibabu ya dharura popote alipo wakati wowote. Yes.
Ding ding ding, we clap for you.
Hey, got it. Yes. Pressure.
All right.
Yes.
So I know we talked about emergency services and how it's not something that we are very familiar with in the country, and they're not very present. We are not aware of them, and we still don't know what to do. So as Dr. Benjamin, tell us a bit of how you got into emergency medicine. Was that always what you wanted to do, and what you're doing currently?
Okay.
Yeah.
So I trained in medicine. We're in the same school.
Were you in UN?
Yeah.
Okay.
Hapo tu. Power UN.
Comrade Power.
Comrade Power, yeah. So I was at University of Nairobi and I did my undergraduate. And I think also it was around the same time we used to have a lot of TV, watching ER and stuff.
By the way, ER is one of the best medical shows.
Exactly. It's actually its most factual. The new one is the PIT, which is as factual.
Yeah, the PIT.
Yes. But ER was very factual.
Yeah.
And so here I was, I'm watching ER, but I also go to school and to the wards, and I'm like something was not making sense. Yeah. I mean, in ER, these guys are exciting. They're living their life. They're saving lives. Ward round, gasping patient. No one seems to be in a rush to do anything. I was like, there's some disconnection somewhere.
Yeah.
And not revealing my age.
You did it, not me. You're the one who did it.
So at that point, I realized there's something amiss here. And I wanted to do what they're doing on ER.
Yeah.
I wanted to go George Clooney. Don't ask. Yes.
I wouldn't ask. I mean, it's self-explanatory.
Exactly. Yes. I wanted to be that doctor.
Yeah.
But this is not what I was learning. And then, and I couldn't understand where the gap was.
Yeah.
So interesting enough, so by the time I was getting into graduation, I was like, okay, so as I said, I knew I'm not going to OB/GYN, I'm not becoming a surgeon. That's another one also.
Yeah,
surgeon.
like why are we standing?
By the
Why are we standing?
breathing our
I
own
can't.
air. Kwanza that mask business.
We learned during COVID, we're like, hey,
this is tough. Yes. So I was like, so I said, that's when Google was also showing up, just discussing.
Hey, you're
So
showing your age.
I was like, explain to me in Google, like, what is this medicine that people practice that doesn't seem to exist here? That's when I actually learned there was something called initially acute medicine, then emergency medicine. And then I realized it's a very young specialty. I think by the time I was Googling this, it was pretty much around 40 or so years old compared to all the other specialties a bit much older. And was mainly in the key Western countries. But on the continent, South Africa had an emergency medicine program. So automatically I knew that's what I want to do. I want to go study emergency medicine and come and practice emergency medicine in Kenya. I think for me that was because the patients were here, but we're not doing anything about it. So got an opportunity to go to South Africa, trained in emergency medicine, which was fantastic. That's like
which university?
University of Cape Town.
Okay.
It's as on ER on steroids.
Wow.
So it's ER on steroids.
You know, that's where you lose me. That's where you lose me. There's like adrenaline.
Let me tell you.
Who's bringing the adrenaline?
Let me tell you, when you get a patient, you get a patient who's been stabbed in the heart.
Yeah.
Like the knife went straight into the heart.
Yeah.
In less than 5 minutes, the paramedics have brought the patient. Okay. You've opened up the chest.
That's good.
You've stopped the bleeding. And tomorrow you're having a conversation with this person. You're having a talk. That's when you realize, this is a different world.
We are far.
Yes. So it was amazing. I mean, I had really awesome training, and I'd recommend anyone who wants to go learn emergency medicine, that's the place to be at.
Okay.
Because they have everything. They have the trauma, they have the heart attacks, the strokes, they have every single thing. And you get to practice it in best world settings. And so came back to Kenya in 2012. And I think for me, it was very clear that we need to figure out how to practice emergency medicine here in Kenya. And that's what I've been working towards and building our emergency healthcare services across the country.
Okay.
Yeah.
You don't want to plug it?
Oh, the foundation.
Yeah, I mean.
Okay, so in 2015, set up the Emergency Medicine Kenya Foundation.
Yeah.
And it's an NGO that works purely with government, national and county governments, to set up the laws, the policies, set up ambulance services, set up public emergency departments. And in the last, I guess, 10 years, we've been 10 years now, we've really gone a long way as a country. So from nothing to now, counties have actually dispatch centers, they have ambulance services, we have policies on emergency care. So we've made some significant progress, and the government has really worked on setting up emergency services. Not there yet. There's a lot of gaps to be closed, but I think we're in the right trajectory, and hopefully in the next, I'd say in the next, by 2030, we should have a number you call and an ambulance actually comes to your house.
We'll hold you accountable.
Working on it.
Okay.
Yes.
I know you've talked about emergency centers, and actually the first time we met, he doesn't remember, but we met in Nyeri County.
Yes.
Into through your foundation.
Yes.
So I think it was either a training or some policy work. I don't remember exactly. But you actually said that, in this county, we don't really have emergency centers.
Actually, it was the whole country at that point. Probably.
Exactly, yeah.
Yes, because the assumption is, and you're told, in case of an emergency, go to the nearest facility to get help. I can tell you for a fact, if you're hit by a bus and you end up in a dispensary, you will die.
That's true, by the way.
Fact, yes. Yeah. So not every hospital has the capacity to provide emergency care. And that's the need to ensure that we have clearly defined emergency care centers. Emergency care centers, essentially, it's, of course, a facility that is open 24/7, has a theater, of course, of surgical emergencies, and personnel, processes, protocols, and equipment in the emergency space to receive you and provide that emergency care. We have that a lot in the private, some of the big private facilities, and we're starting to work with that on the government side, so that in case of an emergency, you need to know which is your nearest emergency center so that you're taken to that emergency center. Because a lot of conditions are very time bound. Okay, severe trauma, you're time bound, so you can't keep bouncing from hospital to hospital. If you're having a heart attack, I think we need to give you the meds within a certain amount of hours, similar to a stroke. So these are emergencies that if you're in Murang'a, by the time you get to Nairobi, give or take, you may be out of time. Yes, and that's the importance of us being able to define emergency centers all across the country, and everyone knowing which is my closest emergency center.
You just mentioned that, and I remember there was the governor, the Nyeri governor, who had an accident, and people are wondering, why was he taken so far to Thika level 5? You're just like, that's one of the highest facilities at that particular time in that
probably
place.
The closest.
Yeah.
And again, the concept of, remember, if you take that story, because that was really a significant, one of the key milestones in terms of emergency healthcare development in the country. He was in an accident on Thika Road. He was trapped in the vehicle. Okay. No ambulance was coming. So, many people see it on TV. Oh, an accident, then lights. Wee, wee, wee. In Kenya, you crash. The sound of bodas is what you'll hear.
The people
rushing towards you. Yes. Okay. And so no one was coming to rescue him. He was trapped in the vehicle for some time. Okay. Until eventually the public are the one who were able to extricate him from the vehicle. He had lost a lot of blood by that time. And then it took, I think, 40 minutes from when the accident happened to when he was able to be removed from the car. So you can imagine 40 minutes of bleeding where no one is actually stopping this bleeding. So he was alive for quite some time. But now by the time he was being removed from the vehicle and then, of course, tried to rush the nearest facility, he was passed on. Yes. And that's the situation every day. It's not, that was one case, but every day someone has an emergency. There is no number to call. There's no vehicle coming for them. And by the time they're able to figure out where to go, even where the help is available, there's no one, it's too late for us to help you. And we saw in the same case, even I think Prof. Magoha, there was some delays in terms of getting him to an emergency care center on time. And their stories are many. There are many stories. So we really
those are just the prominent ones.
Yes, those are the prominent ones. But this happens to everyone, every day, every time.
Yeah, that's true. What is one case that really broke your heart, where you're just like, if we had gotten you earlier, or if something was done, in time, would really be able to save this person?
There's a lot of cases.
Maybe like one that sticks out.
I think it's,
or let me change that. Or like what condition?
Heart attacks.
I think
let me use the Prof. Magoha case.
Okay.
In a Western country, everyone is already attuned. Okay.
Yeah.
You have chest pain, call 911. Okay. Now, in good countries, 911 will come to your house. They will get the ECG done, and they will actually give you the treatment in your house to save your life. In other cases, the ambulance will come and quickly straight to a cath lab.
Yeah.
So that case, if they should have gotten the care they required, I mean, there was no reason to delay. The delays were, and the delays actually come from the fact that what you said, you're not used to having emergency services. And sadly enough, yes, the ambulance is in Nairobi, but of course no one has a number. And because it's been norm for us not to call an ambulance compared to the West. In the West, as long as you're this high and you can talk, you can dial 911.
That's true.
Yes, and services will come. So we also need to start changing our perspective as healthcare providers, and even the general public. As healthcare providers, we need to encourage our patients to call ambulances in an emergency. Yes, not say, come to my clinic. By the time, also that's the other thing. I've seen those cases where someone is busy dying and the doctor is telling them, come to my clinic. But your clinic is not an emergency center. And so by the time they come to the clinic, then the doctors are like, oh, you're busy dying, go to the emergency. That's too late. You've wasted so much time. So if healthcare providers could advise patients, in case of an emergency, call an ambulance, go to your emergency center. So they need to identify what's the emergency center near them. I think that would save a lot of patients, because a lot of delays are because of decision making. Yes. And I think also for the general public, call an ambulance. Find a number, call an ambulance. There's actually an app. Let me just plug this one.
Plug it.
It's called Casualty app.
Okay.
It has emergency numbers, it has first aid guidance. We see too many people. The other one I've seen also is, this is the sad part, is kids also. That one really hurts, because you will see a kid brought in, they choked. Now, choking is something first aiders can sort out in the street. But because no one knows what to do, and I don't know at what point schools stopped teaching first aid and schools stopped having first aiders. So you see a kid choked and died. I'm like,
there was no one to...
Yes, exactly. Simple Heimlich maneuver, simple... I'm like, so why... someone explain how this happened. Because no one should be dying from choking. No child should be dying from choking. Everyone should know what first aid. And even if you don't know, if you had that number, then they'd guide you through it. But these are the cases that really still get to me in terms of, we really need to fix this system.
And choking is such a... If you think about a heart attack versus choking... It's something so small.
And so small, so reversible, so treatable. Like, it's some... And I'll give you another case, just because in the ER you have so many stories. I remember this story. So I was in the ER, this was when I was in training in South Africa. And a mother rushed to the department, so holding her baby, who was still alive, but crying, but like a feeble cry. So the child had been eating a peach. I don't know how a peach ended up in the child's mouth. And... we did just the same maneuvers. Okay, quickly, whatever, Heimlich, back slaps, all that, chest thrusts, and the pitch came out, and the baby started crying. But I can tell you, it was 5 minutes where the world stopped. Because you're busy slapping the baby's back, pushing on the chest, which is the maneuver student. And everyone is watching. You're holding this baby. You and the baby. Yes. And now there's a crowd that has formed.
And you're hoping it better work.
And you're praying. Yes. And all you can hear is slaps and chest. This has to come out. This. So when it actually came out and then the baby starts crying.
What? Sigh of relief. Being a doctor is hard sometimes. Like, when you're in the thick of it, you're like, where?
You were in that moment and that's all you could think about. But hearing that baby cry, everyone getting excited about it, to give the baby to the mother, told the mother, yes, maybe next time don't give a peach to the baby, and the mother went home with the baby. But yeah, so it's those moments, but also the excitement that comes after knowing you actually did save a life. Yes. Now, in our setting, where? That's
even simple CPR, we're not trained in.
Yes. So that's the thing. I mean, we really need to change our mindsets as healthcare providers, general public, and prioritize emergency healthcare services. Because without emergency healthcare services, all the other interventions don't work. I mean, I keep saying this about the maternal child health. Mothers die from bleeding. Now, if she's bleeding in her home and there's no ambulance coming and she can't be taken to an emergency center, then there's nothing we can do.
There's nothing.
So we need to fix some of these things.
That's true. And something else I've remembered is even instead of calling your physician, there's some people who call relatives and friends. And you're just like, you're wasting time.
But they don't know.
It's true they don't know.
They actually, because in other worlds, people know automatically. In fact, the relatives will know 3 days later.
Yeah.
Automatically, they like dial 911 or whatever, and the system takes care of you. Yes. Here, because we've not educated the public and have not established the systems fully. So I'm really happy that some counties now have such systems and they have numbers you can call. But still not nationwide.
I think we have one as Nairobi, yeah?
It's there, but it's not fully
there.
It's there.
Okay.
Yes.
It's there on paper.
Nairobi, you have good private services, which is fantastic.
Yeah.
There are many organizations that provide ambulance
Actually, something
services.
you've said, like these days you see ambulances just parked everywhere.
Yes.
I'm like, oh, wow.
Nairobi operates a lot on private, which is fine because the economic power of the people in Nairobi can. But beyond Nairobi, most of it is now government providing healthcare. And in those places, again, they're remote, they're less resourced. So they definitely... In fact, that's the thing. In Nairobi, while you're dying in your house...
Yeah.
And I've seen...
You have access to
access to ambulance services. And especially if you're going to seek private healthcare, then it's not a cost issue. But you still see a lot of patients, and we've seen this actually. Of course, it's people, their knowledge. You'll see a patient brought in to a private emergency department and they've died. We're like, why didn't you call the ambulance? So they've driven through traffic and spent, and Nairobi
That's
traffic.
another thing.
Yes.
Yeah, that's another
Exactly. So someone was sick in the house and you're like, instead of calling an ambulance, let me drive them to hospital. And you've driven through traffic, of course, which takes forever because you're not an ambulance. By the time you get to us, there's only so much we can do, okay? Versus... had you just called an ambulance, an ambulance comes, pick you up, it's able to maneuver through traffic. These days, thank God, Kenyans allow ambulances to move. So they would be, and the ambulance, remember, ambulance is not just a taxi, it's not Uber here. Ambulance has healthcare providers behind it who will be able to provide that initial care at your home, on your way to hospital. So by the time you're getting to us, something has started, so we are just continuing from there. So I think it's in Nairobi, you should be calling ambulance. They're there, yes.
But I think some of these roads, they just, like, they don't have that room for you to move to the side. Like, it's not built for emergency access.
That's a problem, actually. Again,
because like, where do I move to? Like, sure,
you can't
the
move,
cab is here. Where am I moving to?
No. A good number of our roads do not provide for emergency access. And also just highlights the fact that as we built our healthcare systems, as we built our infrastructure, we never really factored in emergency services.
That's true.
I mean, I can talk about ambulances, but you think about even fire brigades. Yes. But again, even police.
Even
Can you call up police when you're being robbed and they will come on time? And so
might be a delay.
As a service, emergency services have not really been factored in our systems and in our infrastructure. But that doesn't mean we should keep ignoring the problem.
That's true.
And for us, access to emergency healthcare services is something that the good thing is in our constitution now that everyone has a right to emergency medical treatment, and the government has prioritized emergency healthcare services in their policy, in their acts. So there is some work happening.
Okay. That's good. You've talked about some of the things we get wrong and the calling. But what are some of the other things we get wrong when dealing with emergencies? Like things like moving the patient.
There's a lot.
Yeah, what are some of the
Number
things?
one, if someone is having a seizure, please don't put anything in their mouth. Do not stick your fingers in their mouth. Do not try and restrain them. Put cushions around them and turn them to the side. That's it. Okay. So there's a lot of, because seizures is a common emergency out in the streets, and you find people trying to open their mouth. I don't know, doing all but all you need in a seizure patient is put cushions around them so they're not hurting themselves during the seizure. Turn them to the side. Imagine it'll stop. Like, you don't need to intervene beyond that. Of course, then they need to go to an emergency center. Be after that. So that's one. The other thing is thinking of poisoning and people drinking milk. That didn't work. Yes, if you drank poison, then you are drinking.
Okay, I've not seen that.
Oh, the other one. In fact, let me plug this for
Look at the camera
the
straight.
healthcare providers. Please do not do gastric lavage. This thing of sticking a pipe in someone's stomach and pumping them, that's criminal. It's criminal. It is unethical. It has no benefit. It has a lot of harm, and no one should be doing gastric lavage. Please, no one should be doing gastric lavage.
I think I need to go and speak to the people who are making the curriculum, because if it's still there,
it's still, I see.
Yeah.
Like, actually, they did what? Or they put a tube and no, imagine. There is no evidence behind it. So gastric lavage out. Please just don't do that.
Okay.
What else can I say people should not be doing?
What about moving injured patients, especially if someone has lost consciousness?
I think in an emergency, I think if you see bleeding, stop it. Bottom line. Okay. Find a piece of cloth, because the thing that kills a lot of people, especially in trauma, is bleeding. Okay. And there's whole campaigns around stop bleeding, stop the bleeding, and things like that.
Yeah.
So anyone who's bleeding, please stop the bleeding. In terms of moving the patient, there are two aspects to think about this.
Yeah.
The chances of you causing secondary injury, because primary injury is when the accident happened.
Yeah.
The evidence behind bystanders causing secondary injury is very minimal.
Okay.
So if there's a need to move the patient, if there's a need, then you move the patient. If there's a need.
Okay.
But if preferably call an ambulance, let them come and move the patient, and because then they will do it professionally.
Yeah.
But key thing is objective should be stop any bleeding you're seeing, because blood, as I'm sure you've seen so many blood appeals, it's because when you're bleeding, number one, getting that blood back into you, it's an issue. And the more you bleed, the less likely we're able to support and bring you back to life. So stop the bleeding, I think, would be the key thing.
Yeah.
If there is a need for you to move the patient, move the patient. The chances of you causing additional harm is much less. I mean, if someone is in the middle of the highway, them being hit by another car will cause way more harm than whatever you'll actually do for this patient. Yes, but let's learn to call ambulances. Let's promote use of ambulance services, because they are the professionals and they can and will come to you to help you.
Okay. There's one that I see a lot, but I don't think we talk about it much. Burns.
Yes. Burns, it depends on the level of burns.
Yeah.
Okay. For simple burns, the key thing is put it under running water. Yes. Even in hospital, please don't wash burns with saline and drink as lactate. Normal tap water, run it. It has a cooling effect, but also then cleans out the wound, and reduces a bit of the inflammation. So run your burn under cold water. Do not burst.
Oh, that's what I was waiting for.
Do not burst any blisters. Please do not burst any blisters. So blisters, yes, they form after burns and scars. But what the blister also does, because it's in a contained space that is sterile, it avoids infection coming in. Now, the moment you burst the blister, essentially you're exposing yourself now to infection. Yes.
Welcome.
All bacteria come in. Welcome. It's a party in here. And your skin is at that point less protective because of the burns behind it. So do not burst any blisters. The blisters will eventually sort themselves out. Your skin underneath will form and they will blister, but do not burst blisters. And just cool your burns at that water, just normal room temperature water. And go to hospital. So if your burn is significant, you should be going to hospital to be checked.
And I think also this is something that I see a lot in movies. I don't know if you interact with this a lot, but if you've been in a place where there's been maybe a fire, as long as you've inhaled the smoke, please just go to hospital. Inhalational burns, maybe you can talk about that.
So what happens is there are two aspects of inhalational burns. So you could be in a trapped room and it's hot. So because you're breathing in hot air, you may not have burnt, but the hot air burns your insides. And when that burn happens, then your inside starts swelling up and you can easily choke to death. Okay, so that's why if you're in a trapped environment, going. Carbon monoxide poisoning, I think you all know the whole, there's a jiko somewhere, then you sleep, then you wake up and you're dead.
You wake up and you're dead. You wake up and you're dead.
See you in another life. You have to believe.
Yeah.
So you wake up not on Earth.
Yeah,
Okay, is that
okay.
better? Yeah. So you wake up and you're not on Earth. So
Yeah.
carbon monoxide poisoning happens again if there's burning in a trapped room, and you should go to hospital. A good times then you'll be able to pick up if you need additional oxygen, because that's when they give you oxygen for that.
Okay.
So that is something that people need to be cognizant about. But yes, do not be in an enclosed room with a fire, a jiko, whatever fire it is. That
Open the
increases.
windows.
Open the windows.
The door.
Preferably do this fire outside.
Yeah.
Because it consumes the oxygen and then of course promotes the carbon monoxide, which then will poison you, and then you will wake up not on Earth.
Okay.
Yes.
You'll wake up dead. Okay. Now, as we're wrapping up, what are some things that, or rather, how can we prepare a home kit? Maybe like a first aid kit. What are some things we should have, or like things we should know? Yeah.
So this is very simple. Number one, have an emergency number. Okay.
Number
one, find out your available ambulance services and stick those numbers on your fridge. Okay. Stick those numbers on your fridge. Put them on your phone. Put them everywhere in their house. Okay. Sad cases that happen is where you've left your child maybe with a nanny. No, the nanny calling you at work, telling you your child is in an emergency, is not helping anyone. Yes. They should be, call this number.
Emergency number.
Yes, call this number first. Tell them all payments will be sorted. Don't worry about that. So call this number first. And then now second part is also know which is your closest emergency department. So any facility that's open 24/7, has a theater in it, is fairly adequately equipped to provide emergency services. So that's why you should probably go first. So, but the most important part actually, by calling the ambulance, even the ambulance know which is your best hospital to go to. So you call the ambulance, they'll be like, based on what's this condition, the best hospital for us to take you is this hospital because of ABCD. So have that number, okay? And make sure everyone has number. Second thing I'd say is, especially if you have vulnerable people in the house, elderly or your kids, the caregivers must know first aid. Imagine there's some things that you will not get to hospital. Yes, if someone starts choking in your house, they will be dead before they get to hospital. There's some, and that's what it's called first aid. So there's some things that people need to know when they're at home that they need to do that will probably save lives as eventually they come to hospital. So everyone who's providing care or anyone in your house, and also teach your kids.
That's true.
By the way, because it could be you. I mean, you are a hypertensive diabetic.
And they need to save you.
And you're the father. My friend, if you collapse in that house, your kids may be your best survival chance. And so make sure we promote people to learn first aid. In terms of kits, there's fairly a good number of available commercial kits. Red Cross, St. John normally have such kits. And they have the basics, bandages, splints, and that's for basic first aid. And it's good to have a first aid kit in the house for small.
And in your car.
And in your car, yes. That's the law, by the way. NTSA police.
It's the law.
I have said
have a first
the
aid
law
kit.
says you should have a first aid kit. I'm just saying. Yes. No, but yeah. So it's also important. I mean, if you're able to then to help in an accident scene, having a pair of gloves is a very good thing, especially if you're going to support in the community. So I think that's the thing. So have a number. Make sure everyone has that number. Make sure that number is saved and visible in your house. And then 2, learn first aid. Download the Casualty app.
Okay.
That will teach you first aid, and you can actually use it to teach it because it has first aid videos, and you can learn a lot of first aid from that. It has guidance on first aid. When it has AI. Interesting. Yes.
That's the selling point.
That's the selling.
What are you building? Does it have AI?
It has AI. Yes. Okay. Yes. No, but it has. It's what we're really pushing for people because it has the emergency numbers. And it has the first aid guidance, so it's able to help you. So you can get the app, and then let people learn, and then just have a basic first aid kit. Key thing is gloves, especially if you're going out in the community. But something to stop bleeding, though. Anything can stop bleeding. You don't have to have the gauzes, but as long as you're able to put some pressure and stop some bleeding, that'll be good.
And if you can't find gloves, you can.
Yes, please have them. Yes, we got masks. What are gloves?
For us, like as doctors, I think the thing that even adds more time to you attending to the patient is just gloves.
Looking for gloves.
You're just like, where
can
gloves?
I get gloves?
Because you're told to protect yourself first, because you can't protect someone if you're not safe yourself.
If you are busy dying yourself, then how are you protecting each other?
Exactly.
Yes.
All right. That's cool. I think that's a lovely conversation. I would like to have you again, maybe when there are further updates.
Sure, no problem. Anytime.
So for now, before we go to the beyond the clinic,
yes,
right off the bat, stroke care. when I'm looking at someone who potentially is having a stroke, what are the signs I'm looking for?
And this is important. Again,
Yes.
so stroke is one of those conditions that if you do not get help within, if you don't get to a stroke center, let me just define it as a stroke center. If you don't get to a stroke center within 4.5 hours, good chance we may not be able to do much for you.
Yeah.
Okay, so the timeline is quite short. And the things to look out for, I mean, there are new other sciences, but you work with 4.5 hours.
Okay.
So anyone who sudden confusion or slurred speech, they're not talking there used to be normally, one side of their body, either arm or leg, is not working for some reason. It's not working normally. They're feeling weak on one side. So there's that mnemonic fast. So the face, you can see their face has skewed a bit because one side is the muscles have become paralyzed. And then the slurred speech. Okay, arm drift is when if you ask them to put their arms this way and one arm can't stay up, that's the arm drift. So facial weakness, arm drift, slurred speech, and the T is the time part because you have a very small window that you need to get to a stroke center. Now, in terms of what a stroke center must have a CT scan.
Yeah,
So if where you're going doesn't have a CT scan, it's not a stroke center. That's the first part. Then there's the special drugs that you need to get. And I know there's a push to get all of these drugs into the system. So, but if a key category is must be a CT scan because we need to give this drug to you as soon as possible. And so I think, so worry about, because in fact, there was one case I was being told about, which was very concerning, is someone healthcare provider hand had stopped working and he just continued. I'm like, my friend, but then we see strange things in the emergency. I'm like, you when your hand couldn't work, see, you should have come.
But they say doctors make the worst patients.
I'm like, you came in 3 days later. I'm like, huh? Yes. So if any of those let me also just talk about heart attacks because of the high burden of non-communicable disease, hypertension, diabetes, heart attacks and strokes are like water these days. Everyone is, if you've had anyone suddenly collapse and die, it's probably a heart attack. And then the stroke is the paralysis that we're seeing that. Now, if you're having any chest pain, okay, shortness of breath, okay, or arm weak, you're feeling like a tingling sensation or pain in one arm, please run to the hospital, okay? Especially if you have the risk factors. You're a bit old, hypertension, diabetes. We need to give you medication to open the blood clots in your heart. Otherwise, you may die or have heart failure, which is terrible. So let's also learn the emergency signs for some of these conditions because it's important you get to a facility that can treat you sooner.
Okay. Now that you've talked about that, we can't live without you talking about DVT and pulmonary embolism.
That's the same. So in fact, the pulmonary embolism is the whole sudden shortness of breath.
And
chest pain, shortness. So there are like 5 life-threatening causes of chest pain. I spoke on heart attack because that's easier for people to understand. But what you're saying is correct, the pulmonary embolism. And that's also an emergency cause of chest pain and shortness of breath. So that's what I'm saying. If you have any chest pain and you have shortness of breath, and this one now cuts across not just your hypertensive diabetes or your pulmonary, just run to hospital. Yes. Let them check it out because you could be on the way out if nothing is done. Yes.
Okay. I'll have actually later on in the year an episode on DVT, so I guess we'll cover more of it there.
Happy to. Yes.
In such an interesting story because the lady who got a DVT and then a PE, and she was on birth control for her acne.
Oh, she had all the risk factors.
So it's least expected. Like, it's just for your acne.
Oh, but yes.
I know. Like, you know that as long as you're on estrogen-based family planning, these are risks. But I was just like, where? Anyway.
It's a problem. But pulmonary embolism is big. We get a lot of them. In fact, I've seen so many. But if you show up on time, that we can try and figure a few things out. And there's treatment for that at least. Yes.
I think the take-home message is with emergencies, time is of the essence.
Time.
Yeah,
By the way,
time is of the essence.
And this is time between you being alive and not being alive.
Yes. Or ending up with disability.
Permanent disability. Yes.
Okay. So now let's go beyond the clinic.
Yes.
Or beyond the hospital.
Beyond the emergency department.
Beyond the emergency, the ER.
Yes.
All right. So if you had to text your patients one simple health tip.
That is what I don't talk
I know you don't have patients. But if you had to text your patients one health tip, what would it be?
I'd send them an ambulance number. Yes.
Okay.
Save this number. There are a few companies, private companies, that have national reach. I'd send them those numbers and tell them, save this number. If you ever feel like you're in an emergency, just call this number.
Yeah.
Yes, I think
Are they in the casualty app?
Yes, they're in the app. Yes.
Good.
Call, if I'd send them the link to download the app.
Download this app, please.
Yes, but I think the messaging also is just, here's a number, save this number, call an ambulance.
Yeah.
Imagine, you can, it's not you just call an ambulance. Yes.
Okay, that's a very good one. All right, next question. What's the first thing you do for yourself, either the first or the last thing you do for yourself, either in the morning or in the evening, that's just for your sanity? Like, no one has to understand it. It's just for your sanity.
Sanity is overrated. But let's have...
And on that note...
I find it's nice to live on the edge a bit. So yeah, sanity is overrated. But for my own sanity, what do? I will quietly just listen and just listen to some music. Just music playing. Actually, that's what my alarm is set up that it's music that's playing.
Okay.
So that I wake up to nice, good, simple music.
Wow.
Yes, then so I'm listening to the music I'm trying to figure out this day is gonna go. Yeah, so that helps.
You're setting up your day because once you land in that ER,
in fact, once your
chaos.
feet leave the ground,
that's why you think sanity is overrated, because of where you work.
Yes. But sanity, you think about it.
But
living
actually,
on the edge kidogo is not a bad thing.
But now that you're saying that, it reminds you of the conversation we were having before this about social media.
Yes.
Please tell them what you said about social media.
I shall not be quoted. No. I think I saw this I still saw it on social media, but someone actually was saying social media is like a psychiatry ward without the attendance. And I could not agree more. Yes. There are a lot of people walking around this society that would meet DSM-4 criteria.
Whoa.
But are happily living in society.
That's true.
So social media is like a psych ward without the attendance. Yeah, that's my take home on that one.
So take it with a pinch of salt.
Yes.
Okay. Next question. Was there a moment, either recently or whatever, maybe it's today recently, with either you or a patient or in your training where you thought the body is so wild for doing that? Like, why would you do that?
Every day. I mean, I think the amazing part is how much resilience and how much your body is designed to fight.
Okay.
I think that amazes me every day because, as I was telling you, you could have a patient who everything is shutting down and they just a bit of boost and your body starts picking up. So you're seeing someone move from pretty much death and you, with a bit of support, the body starts fighting back and slowly by slowly. So it amazes me how much our bodies, if well taken care of, have what it takes to fight disease, what it takes to stay alive, but also just the human willpower to stay alive. I think that fascinates me. It's amazing to see the science. In fact, I think we're discussing somewhere about, I know there's this whole discussion about AI and if AI can take over your body and things like that.
Yeah.
But even with the best scientists so far, they've not been able to replicate the human body.
Yeah.
It's just a fascinating thing. Yes.
I think that's nice because yours was a positive one.
Yeah.
Most of the responses I've gotten were on the negative side, which I think is normal because you're just like, hey, that's wild. But yours is positive.
No, there's a lot. Yes, it's
where you work.
The body.
Let me just say, it's where you work. Okay, the next question is, what's a piece of health advice that maybe you received a few years back that you no longer agree with? It's okay to be controversial.
What do I not agree with? This was my own health advice, or someone mentioned something?
Maybe someone mentioned, maybe you read it somewhere, you saw it somewhere.
I think, wow, this is a very interesting one. I think it was around the COVID time. Because everyone was coming left, right, and center with advice on things to do.
Yeah.
And it was people who are wilding it.
Yeah.
Again, being the front line for any facility, the emergency department, we saw COVID patients firsthand before anyone at the back end of the hospital saw them. And so I think there are some things that people were doing, like This is controversial. Those ones who started washing fruits with soap and water, scrubbing them.
You decided to go there.
Those ones, I was like, yes. So your mango will give you COVID. I was a bit skeptical about that one.
Okay.
And I think, yes, I think that one. Yes. Okay. Oh, wash. I'd tell you for a fact.
Yeah.
Okay, fact, not fact. A bit of jams is good for you. Yes. I think your body, again, remember, your body builds memory.
Yeah.
So constant exposure to small doses, small manageable doses of infections and whatever builds your immunity. Living in a sterile environment essentially sets you up for disaster when your body now faces an infection.
Yeah.
So yes, that whole idea of let's sterilize the whole world. Yeah, I think there's
that's a very lovely controversial take. I love it. I love it. But it's true. And that is how vaccines work as well. Yeah.
You need a bit of exposure to disease for your body to build the immunity.
Yeah.
If your body has not built the immunity, even a small common cold will kill you.
Yeah, it's going helter-skelter.
It will gonna finish you.
Yeah.
Yes. So, yeah, there's that.
All right. Last question. What's a health rule you think we should all break every now and then without feeling guilty?
It's a food thing.
Okay, this is the second food one I'm getting.
You see, everyone thinks, it will tell you as healthcare providers, everything is bad for your health. Chocolates are bad for your health. Just Valentine's, that was just what we were working with then. Sugar is bad for your health. Alcohol is bad for your health. Smoking is bad for your health.
Yeah.
A lot of these things are said to be bad for your health. The thing that people need to understand is there things are bad for your health when you overdo them. Okay? Overexposure to it. Okay? If you're gonna eat chocolates Monday to Monday and probably 5 bars of sugar, I don't know how much sugar, then it's gonna eventually get to you. Yes. So everything done in moderation is okay.
Oh, perfect.
Done in moderation, okay? And the guidelines as to what exactly moderation is.
Yeah.
Smoking maybe is bad for the environment, and too much of it will also kill you.
Just the environment.
There's many things, too much of it. But I'm not saying it's good, no.
Yeah.
I think that one has evidence of cancer and things like that.
Yeah.
But a bit of sugar, a bit of salt. Not too much salt, that's the thing, because we also then tend to do everything badly. Like
exactly.
Too much salt, too much sugar. Too much laziness also. That's the other thing also. Everyone was like, okay, so you need to go to the gym and build muscles. You need to exercise. No one says you need to be Arnold Schwarzenegger, okay? So you need
Slow
to
down.
Exercise regularly. Do not sit too long. Moderate what you're eating. Avoid too many processed foods. Yes, so everything in moderation. And you'll probably live a healthy life. Yes, because I think I've seen people doing both extremes where you are not doing anything. Like you're eating extremely healthy, which then you're probably, I don't know how you're enjoying your life. And then, there's a little...
I know.
Yes. And then this other side, you're binging on everything and you expect to live a healthy life. No. You need to be somewhere in the middle, okay? And yes, everything in moderation.
Okay.
Yes.
All right. So we have reached the tail end.
Oh, awesome.
And this is the moment where if you have a parting shot or if you want to plug yourself, the camera is yours.
I'm just saying, as usual, just call an ambulance and get the casualty up. But it's been a great conversation.
Yeah.
Wait, do we get to ask you a question?
You can ask one. Moja too.
Well, we're being limited.
Okay, fine.
You asked me like 10, 15.
Okay, fine. You can ask. We're being told time.
All right. I can get 2 questions.
Okay.
Right. So, let's see. From your experience on podcasting so far, what have you learned? What have you learned so far about interviewing all of us?
I've learned that you can't know everything. So every moment is an opportunity to learn. So I learn from every conversation. And then number 2, what I've learned is people are people. So whether or not you give them all the information, all the resources, they will still do what they want to do.
Right. Yeah. Good. And second one is... I remember in the beginning you said like, subscribe, that one. So it's my social media.
It's not on social media, in case you're wondering.
So why do you want us to subscribe your show?
Why?
Yes.
Because I want you to first of all, I want you to be responsible for your own health. I want you to participate in it. And I want you to help us. So we already have an overburdened health system. So imagine what an informed patient would do for that system.
That's a good point.
Yeah.
Echoing that, yes.
Yeah.
What she said. Yes.
So
Thank
for
you.
me, it's just building informed patients who help us help them.
Awesome.
Yeah.
Thank you.
You're welcome. Okay, guys, welcome back to A Dose of Health. It was now EMKF. But no, to wrap it up, my name is Dr. Hope Simiu. This was a lovely conversation. If you've stayed until this point, please like, share, subscribe. Tell us about some of your emergency experiences and probably what you'd want to know more about emergency services in Kenya or just emergency response. And that's a wrap.
Thank you.